Human Services Committee will come to order. Ms. King, please call the roll.
Representative Morrell.
Present.
Bradfield.
Yes.
Bradley.
Here.
English.
Here.
Gray.
Here.
Hamrick.
Here.
Johnson.
Here.
McCormick.
Here.
Ryden.
Here.
Mr. McKay.
Here.
Woo.
Here.
Peter.
Here.
Madam Chair.
Present. Thank you all for joining today. We're going to be hearing 3 bills, 1002, 1024, and 1064, and then the sunset review of the Colorado Licensing of a Controlled Substance Act. So we'll go ahead and get started. Witnesses will have 3 minutes to provide testimony, and with that, I will turn it over to Vice Chair.
Thank you, Madam Chair. So I'll give you a second to get over there and smack, and sit next to Brown.
You're first.
Welcome back to
Thanks. Just when you thought you never had seen me.
Okay, we're gonna go ahead and get started. Our first bill here today in Health and Human Services will be presented by Representative Gilchrist. House Bill 1002. Go ahead.
Thank you, Madam Chair. Thank you so much for the time today to present House Bill 1002, which is aimed at improving access to behavioral health care services in Colorado and strengthening the workforce. I've heard from many Colorado families who can't find behavioral health providers despite having commercial insurance coverage. Many times, the providers they reach out to on their insurance directories are not available, not accepting new patients, or not actually in network. These ghost networks make it harder for patients to find care. Can you imagine being a parent of a child who's experienced a mental health crisis, and you're given a list of providers to call, and you spend hours calling one after another with no luck? Your kid's in crisis, and now that situation is worse because you can't find a therapist that is covered by your insurance. The U.S. Senate Committee on Finance conducted a secret shopper survey to understand ghost networks and released a report titled Majority Study Findings Medicare Advantage Plan Directories Haunted by Ghost Networks. Staff reviewed directories from 12 different plans in a total of 6 states, calling 10 systematically selected providers from each plan for a total of 120 calls. Only 50% of the calls made to Colorado provider listings resulted in a possible appointment for the patient. I've also heard from behavioral health providers who want to be in network with insurance carriers, but after they apply to be in network, they don't hear back for months, and then those providers are unable to serve uninsured patients, and our communities lose access to covered care. Coloradans are 11 times more likely to see out-of-network therapists than a comparable physical health specialist. 11 times more likely. This creates higher out-of-pocket costs, delays in care, and other negative consequences for patients and families. This is why we're bringing this bill forward today, to take the first step to addressing these pressing issues.
Representative Brown.
Thank you very much, Madam Chair, and it's wonderful to be with you all again. I miss you. Thank you for not throwing, most of you. Thank you for not throwing things at me today as I enjoy redoing the committee. I think we all agree that we are in a mental health crisis. There are too many Coloradans that cannot get the care that they need. And at the core of that is making sure that we have an adequate mental health workforce. All 47 of our rural and frontier counties are mental health shortage areas. And there are projected to be 4,400 positions in the mental health workforce space that we are short as a state in 2026. The demand for services is outpacing workforce growth. So we need to be doing everything that we can on the private health insurance side to be fighting this mental health crisis and the workforce shortage that we have. I'm gonna focus my remarks today on the strike below, which was circulated yesterday. For our intents and purposes today, that is the bill. We will be, during the amendment phase, we will be moving the strike below And so I will direct your attention towards that. The strike below that you have in front of you, L001, represents a month of work with key stakeholders, including the Colorado Health Plan Association, or Colorado Association of Health Plans, Kaiser, Children's Hospital, the Colorado Hospital Association, our partners in the provider community. And I just want to thank everyone for being at the table. This has been a really collaborative effort in many ways. I know that not everyone is super happy, but we have really gotten most folks to a good place, and we continue to work with those who still have concerns. As I mentioned, the strike below I'm going to focus on today, and there are really three critical pieces within it. First, we're addressing this concept of ghost networks, which Representative Gilchrist mentioned, which is where people are calling up folks in a provider directory or that should be in network, and maybe they find that that person doesn't exist anymore, or they moved, or they died, or whatever it is. And so we're asking insurance carriers to confirm provider participation in their networks for mental health providers at least once every year. In particular, it's for those who haven't submitted a claim or otherwise communicated intent to remain active. Carriers are required to update their provider directories quickly when inaccuracies are reported, ensuring patients can reliably find in-network care. And if providers do not respond after a defined period of time, they will be removed from the provider directory and network. The second aspect of the bill tackles timely credentialing by directing insurance carriers to complete their credentialing for mental health and substance use providers within 60 days. So a provider wants to be in a network, wants to be contracted with the carrier. They need to be given an answer essentially in a timely period of time. They don't have to be included in the network, but they do need an answer quickly. The strike below moves that timeline to 60 days. This is similar to the framework that's established by Senate Bill 21-126, which requires that physician-level providers are credentialed within 60 days. So we're aligning behavioral health and doctors with the same credentialing standard. Faster credentialing allows providers to begin seeing patients sooner and improves the timely access to care, reducing the pressure on overburdened providers. Third, we are supporting pre-licensed providers by allowing them to be reimbursed for services that are delivered under the supervision of licensed behavioral health providers. Many insurance carriers already do this, and we're just creating consistency among all those plans. This helps expand the workforce, alleviates overburdened caseloads, and reduces wait times for patients, while also supporting early career providers in gaining supervised experience. Finally, in our conversations with the social workers of Colorado, we are just slightly revising the social work candidate requirements. We are in order to make sure that it aligns with National Social Work Compact standards. The current Colorado law requires 3,360 hours, and we're moving it down just slightly to 3,000 hours to be based on national standards. This will help to get social workers into the workforce as quickly as possible while being in alignment with the best practices nationally. We have one additional amendment in addition to the strike below, so we will move it to the strike below amendment, and that cleans up the pre-licensure reimbursement language. And we worked specifically on this with the Colorado Association of Health Plans to make sure that psychiatric nurse practitioners are also specifically included in the bill. We hope that these changes create a clear and standardized and practical framework for commercial insurance participation for mental health and substance use providers. And I'd be happy to take any questions.
Thank you. Any questions, committee? Dusty?
No, I already said
Representative Johnson.
I want Representative Dusty. We're working on this. We can drop the last name, but I appreciate it. She said Dusty. Thank you, sponsors, for bringing this. One thing I just have to note, because I love the coincidence that last year's bill was also 1002. my question, and I know this was probably more for Rep Brown because he's worked in the department. Can you explain the 30,000 and what that needs to go to if this is putting it on them to follow all this paperwork? Where's the money aspect following? Does that make sense, or can you address?
Yeah, you mean the 3,000 for the social workers? Is that what you're talking about?
Rep Johnson.
30, oh, the 30,000, oh, yeah. So the fiscal note, thank you. As appropriations chair, this one hurts me a little bit. We have had many extensive conversations with the department about their needs. I believe in my communications that they have indicated that based on the strike below and the way that we have changed the language, that they no longer need this. They can clarify, but they believe that they, I think, no longer need this appropriation. I know that our fiscal analyst is still looking at their rationale to make sure that our fiscal analyst agrees and that LCS agrees with that. So for now, the $30,000 appropriation remains. I think it was originally included in the bill because there was a rationale that the Division of Insurance would need to create some sort of rule or process by which the sort of pre-licensure candidates were approved, and to standardize that across the carriers. I think what we are saying in this particular strike below is that the division doesn't really need to do that because carriers are already doing it. But we will continue to have that conversation, and obviously it will be up to the appropriations committee whether it'll be up to LCS whether the fiscal note gets revised, and then it'll be up to the appropriations committee whether or not it can move forward.
Thank you. Follow up, Rep Johnson.
Yeah, no, thank you. So could possibly expect that this brings down the fiscal note based on both amendments. I just also have to say, just because we haven't had you in committee, I appreciate the petition clause. So thank you.
I knew you were gonna love that. I knew you did.
Representative Gilchrist.
Thank you, Madam Chair, and thank you, Representative Johnson, for the question. I also wanted to just comment on your 1002, although totally different bills from the bill last year, both addressing mental health. I think we'd love to have a 1002 every year until we can solve the mental health crisis in Colorado.
Thank you. Representative Bradley.
Thank you, Madam Chair. So I did a little digging. I get where you're coming from with this bill, and I definitely want to solve the mental health crisis, but as a provider, seems like a lot of moving parts. And so I wanted to know if you had based this on other models from other states, because when I looked it up, it seems like New York found pervasive ghost networks, forced corrective actions directories, failed consumers, California, Oregon, Pennsylvania. I mean, it's everywhere. So I'm wondering what we're basing this model off of, because as a member of the JDC, you know you're cutting provider rates substantially this year, and to put more on providers to make sure they're on these networks, not on these networks. Insurance carriers are going to do it. I'm just wondering, because it doesn't seem like these other states have figured out the right model. So I'm wondering what's the right model.
Representative Brown.
Yeah, thank you, Madam Chair and Representative Bradley. I appreciate your question. I think, I'm going to let our proponents speak to that, but I think you will hear from providers that they are in support of this bill, in part because I think they are recognize that, particularly on the credentialing side, that can be a significant barrier for them participating in the network in a timely fashion. The idea here is really that insurance companies and their providers regularly communicate, especially electronically. It's an easy process. And if you are a provider and you haven't submitted a claim, then all you need to do is just affirmatively say once a year that you still want to be a part of that network, and nothing really changes for you. So I'll let them. We also have experts that can speak to some of the experience in other states and where this model comes from.
Representative Gilchrist.
Thank you, Madam Chair, and thank you, Representative Bradley, for the question. And I really appreciate your concern about providers. I think we share that, which is why we wanted to make sure that this was an opportunity for them to get credentialed quicker and within the bounds of the credentialing process, but to move things along faster so that they can see their patients, which we all know providers want to so desperately. And that Rep. Brown mentioned this in his opening remarks, that this aligns now with credentialing for for physicians in the physical health space too. So feel like we are striking the right balance of putting in place certain measures that ensure that we have providers in the network that can serve patients, and also not putting too much restriction around that would make it harder on providers.
Representative Bradley.
Thank you, and thank you for that. I will definitely ask some questions. The Senate bill that you referenced, aligning MDs to the same credentialing, have there been any problems with that? I, of course, have questions about safeguarding patients, which I think we all do. PTs can't practice until they're state licensed. PTs, PAs, NPs, for the most part, what I looked up. So we don't get paid for medical billing until we are state licensed. So I just wanted to know, are there safeguards? Have you seen any problems with Senate Bill 121 or whatever Senate bill you had talked about, where MDs had problems with the credentialing standard or anything like that?
Representative Brown.
Thank you, Madam Chair, and thank you, Representative Bradley, again, I appreciate that. So it's important, I think, to note that MDs also cannot practice until they are licensed. And what we're talking about here is, once a provider has been licensed appropriately by the state, how quickly does the insurance company do their work to determine that they are appropriately licensed and have the appropriate credentials to be in the network? And so this is really about the process of getting enrolled in the commercial network, and less about whether or not a doctor or a behavioral health practitioner can practice in the state. I will also note that I think on the credentialing timelines issue, there are a number of states that have credentialing timelines similar to this. I think it's in the dozen or so, but again, I'll have more experts that'll come and clarify that. In terms of the GHOST network piece of this, I believe New York, New Jersey, but also Oklahoma and Illinois have also implemented similar things.
Thank you. Any further questions, committee? All right, we'll go ahead and move into witness testimony. And I call up your name in the order that they have chosen. Please come to the front and state your name and who you represent for the record. And if I mispronounce your name, please correct me. Kara Cheevers, Veronica Bell, Leanne Root, Ryan Burkhart. This will be panel one. It'll be the button right by the plug, the smallest gray button there. And we'll start from my right and go down the road. Please state your name, who you represent. You have 3 minutes.
Thank you. Thank you, Chairperson Leader and committee members. My name is Kara Cheevers, and I serve as the Vice President of Coverage Policy at Inseparable, a nonprofit founded on the principle that mental health is inseparable from our physical health. I'm here today in strong support of House Bill 26-1002. This bill tackles a problem many Coloradans, myself included, know all too well. We have insurance coverage for mental health care, but aren't able to find a provider in network when we need one. Experiences like mine aren't just anecdotal. A 2025 U.S. Senate Finance Committee secret shopper survey, as has been mentioned, found that in Colorado, only about half of the calls made to listed providers resulted in a possible appointment for patients. Further, Coloradans with commercial insurance plans use out-of-network care at 11 times more often than comparable physical health care providers. That's deeply concerning, especially when 1 in 5 Coloradans experience a mental health condition, and more than half of those seeking care report they couldn't get an appointment when they needed one. But this is not just a patient access issue, it's also a workforce issue. Mental health providers face long and unpredictable credentialing timelines, unclear participation requirements, and inconsistent reimbursement, especially for supervised pre-licensed candidates. This bill offers a practical, balanced solution. First, it sets a clear 60-day credentialing timeline, aligning mental health providers with existing standards for physicians. Second, it improves network adequacy and provider directory accuracy standards by requiring regular verification of provider participation and timely updates to those directories so that patients can rely on the list that they're given. Third, it ensures that services provided by supervised pre-licensed candidates are reimbursed by insurers, helping expand the workforce, reduce wait times, and support early career clinicians. And finally, it aligns social work licensure hours with national best practices to get trained professionals into practice more quickly. I've been deeply embedded in this policy, and I'm happy to answer any questions about this bill or similar requirements in other states. I respectfully urge your support for House Bill 26-1002. Thank you.
Thank you. We'll just go right on down the line.
Thank you, Madam Chair and members of the committee for the opportunity to be here today. My name is Leanne Ruff. I'm a licensed clinical social worker and the executive director for the National Association of Social Workers, Colorado chapter. NASW Colorado is currently in an amending position on House Bill 26-1002, and we're here today in strong support of the strike below amendment that you have before you. I want to take a moment to thank the bill sponsors and the other proponents for their partnership and willingness to work with us on this bill. And I'm here to specifically speak about the portion of the strike below amendment that addresses an important point of clarity related to licensed clinical social worker licensure. It confirms that LCSW applicants must complete at least 2 years of supervised practice that includes training and work experience in clinical social work practice, totaling a minimum of 3,000 hours over that 2-year period. As the bill was originally introduced, the language could reasonably have been interpreted to suggest that all 3,000 hours must be strictly clinical in nature, and that is not how social work licensure functions in practice currently, and that's not how competency is built in this profession. Supervised practice for LCSWs appropriately includes both a combination of direct clinical work and related professional activities, and this amendment corrects that ambiguity. The adjustment from 3,360 hours to 3,000 hours is modest, but it's meaningful. It allows qualified clinical social workers to reach licensure slightly sooner, which matters in the context of our workforce needs. It also aligns Colorado's licensure framework with the Social Work Interstate Licensure Compact, which this legislature has already adopted, and which uses a 3,000 hour or 2-year standard for LCSW licensure that most states now follow. More broadly, NASW Colorado supports the direction of House Bill 26-1002 because of what it means for social workers who serve clients with insurance. Predictable, enforceable credentialing timelines reduce administrative limbo and support practice sustainability, and they allow clinicians to begin serving insured clients more quickly. That certainly benefits providers, and just as importantly, it improves continuity and access to care for patients. We respectfully urge the committee to support this amendment and the bill. Thank you for your time, and I welcome any questions you might have.
Thank you. Next.
Good afternoon, Madam Chair and members of the committee. My name is Veronica Bell, and I represent the Colorado Behavioral Health Care Council, the statewide membership association for the community-based mental health and substance use disorder treatment safety net providers. I'm here today to urge your support for House Bill 1002, which takes practical steps to increase access to behavioral health care. In particular, I want to highlight page 8, lines 6 through 17 in the introduced text. This section requires commercial carriers to admit pre-licensed providers, individuals with master's degrees working towards licensure, into their networks when they practice under supervision and reimburse the services provided by those individuals. The strike below does not change the substance. Community-based safety net providers are the primary training ground for Colorado's behavioral health workforce. We hire newly graduated clinicians with master's degree who are completing required supervised hours to become licensed. These pre-licensed providers are not students, they are real regulated providers. Medicaid reimburses for care provided by these professionals, yet many commercial carriers refuse to do so, and that creates 3 problems. First, it worsens the workforce bottleneck. When clinics can't bill for services provided by pre-licensees, they are less able to hire and retain early career clinicians. Second, it limits patients' access. Even when a clinic has capacity, patients may be told they can't see a qualified supervised clinician because their insurance won't cover it. And third, it disrupts continuity of care. Clients may establish strong therapeutic relationships with a pre-licensed clinician while enrolled in Medicaid, only to lose access to that clinician if they later move to private insurance. The bill offers a common sense solution by simply requiring commercial insurers to follow standards like Colorado Medicaid. Also want to note that the bill takes other important steps to improve access, expediting credentialing timelines, and requiring carriers to take meaningful steps to ensure up-to-date and accurate provider directories. Safety net providers are the backbone of Colorado's behavioral health system. We serve the patients others cannot, and we train the providers the entire state relies on. HB 1002 will expand access to care and ensure safety net clinics are financially viable. I respectfully urge you guys to vote on HB 26-1002. Happy to answer any questions.
Thank you.
Good afternoon, Madam Chair, members of the committee. My name is Dr. Ryan Burkhart. I hold many roles here in Colorado. I am the Executive Director of the Colorado Counseling Association, which represents the largest branch of mental health professionals in Colorado, licensed professional counselors. I am Dean of the School of Counseling at Colorado Christian University, which is one of the largest mental health programs in the country. I have 1,700 students, 700 of which are here in Colorado. I will produce 450 new mental health professionals in the next 6 months to practice in Colorado. I'm CEO of Momentum Counseling and Consulting Board in Colorado. We have over 100 professional counselors and mental professionals on staff and provide about 4,000 mental health appointments a month. I'm also a legislative and ethical consultant for FEDA Law, which represents mental professionals whenever they get in trouble with DOR. There's a lot of different roles that I hold, but interestingly, in all these different roles, I'm able to see mental health professionals from their first day of class all the way through 20 years into practice. I am here today to urge you to support HB 26-1002, and I'm hoping to maybe kind of peel back some of this and talk to you about it from a practical standpoint if I can. There's two things I want to talk about why this bill is important. When we're talking about pre-licensed individuals, we're talking about people who are between their master's degree, they've already completed their master's degree, they're graduated, and they're working towards full licensure in Colorado. Now, these individuals are providing clinical mental health services to anyone they want to provide clinical mental health services to. And typically, they're regulated to clients who can only do cash pay because they're not able to get paneled with insurance companies, which means clients who aren't able to afford cash pay, which is expensive, are not able to see these mental health professionals because they can't get paneled with insurance companies or most insurance companies. So what we're seeing is a significant segment of our client population who does not have access to a very large portion of mental health professionals because they can't afford to pay cash pay. So Representative Bradley, to go back to the questions you were asking about guardrails, these individuals are already providing services to your constituents. They're just not able to provide services to your constituents who want to use insurance. And this bill would directly address that. The other thing that's happening is whenever a mental health agency hires a licensed professional, mental professional, I've seen it take 3 to 6 months for that mental health professional to get paneled, which means they have to operate at that agency without being able to see clients from that insurance panel. So they're operating at a reduced caseload, and that mental health agency is having to basically eat that loss of revenue, still give them a paycheck. But for the first 4 to 6 months of their employment, they're not a full revenue producing employee. That has dramatic impact on the mental health workforce. I'm more than happy to answer additional questions.
Right on time, thank you. Okay, is there any questions for the witnesses? Rep. Bradley.
Thank you, Madam Chair. Thank you for your testimony. I did not get your name, from the National Association of Social Workers. Can you tell me what other states have decreased social work hours, and did it increase access without any problems? Is the risk versus the reward kind of thing?
Thank you, Representative Bradley. Thank you, Madam Chair. Leanne Rapp from MSW Colorado. So I can tell you that broadly, the national standard and national average is 3,000 hours of supervised practice over a minimum of 2 years postgraduate school completion. I can also tell you that a lot of research was done in the development of the Interstate Licensure Compact for social workers, which has been out in the wild and running legislatively through states for the last 2 years. I think we have 31 states and counting right now that have passed that legislation. And the commission is actively developing that compact, hoping to release those multi-state licenses in the next year or so. That being said, in that research, they found that I believe over 30 states in the country require 3,000 hours as their standard for LCSW licensure. Those states do not notably have any increase in the number of violations of Practice Act requirements or uptick, in violations. They do see access to licensure more quickly because those folks are able to acquire those needed hours for licensure in a more expedient fashion because of that decreased number. I hope that answers your question. Yeah, thank you.
Thank you. Representative Ferre.
Thank you, Madam Chair. Dr. Burkhart. Is that right? We have about 8 minutes left. If you want to continue with the titles that you have, that would be great. I wanted to, you said something about paneling, 3 to 6 months around paneling. Can you explain what paneling is for some people?
Dr. Burkhart.
Thank you for your question. So the process that we're hoping to try to address is that there's two things. One, when you are a pre-licensed professional, you're not able to seek basically authorization from an insurance company to see their clients and seek reimbursement. That's where the whole cash pay dynamic comes in. So if you're not paneled with the client's insurance, they want to see you, you're paying that clinician's full rate. And we're talking $135 to $250 an hour at that point, depending on experience. So what we're seeing is a significant portion of our population who just can't afford to pay that. So while we may have, I think, roughly 25,000 mental professionals in Colorado, there's a significant portion of those that are kind of being regulated to cash only. And that prevents services. So once they become fully licensed, they can then seek paneling with various insurance companies, whether it's Blue Cross Blue Shield, Cigna, Aetna, Medicaid. And once they get paneled and approved, they can then begin seeing clients who have an insurance and then billing that insurance agency. But that process can take 3 to 6 months. So as they're onboarding to a new mental health agency, it is a significant financial burden on that agency to be paying an individual paycheck for the first 3 to 6 months of employment, when they're not able to see the full client base because they're waiting on that paneling process. And the beauty of this bill is it really kind of removes some of those barriers for people who are fully licensed, who are providing clinical services to clients, and those people who are recently licensed, starting at a new agency and seeking paneling.
Thank you. Any other questions? All right. Seeing none, we'll move on. Thank you so much for your testimony. Now, we're going to bring some people up online. Anyone who is in opposition who signed up or an amend witness, please come up, and if you could bring up online Kevin McFatridge, Dr. Mark Longshore, William, and Susie Hildado. Those are all remotely, if you could bring them up. And anyone else in opposition or amend position? Okay, we'll start in person while she's bringing them up. Please state your name and who you represent. You have 3 minutes.
Chair and members of the committee, my name is Kevin McFatridge on behalf of the Colorado Association of Health Plans. First, I want to sincerely thank Representatives Brown, Gilchrist, and the advocates on the bill for their thoughtful engagement on HB 26-1002. We truly appreciate the time and attention that has gone into working through our concern and amendments that are being offered today. The changes related to directory verification timelines, clarification around electronic communications, alignment of mental health credentialing with existing credentialing standards, and the removal of the applicability of the bill to Medicaid reflect meaningful collaboration. We are also grateful for the clarification that completed applications will be treated the same way as they are now, including a signed contract and any other criteria a plan has in place. The strike below amendment represents the diligence and hard work that the sponsors had in engaging with CAP. With the committee's adoption of the strike below amendment, CAP will be moving to a neutral position on HB 26-1002. We appreciate the collaborative approach taken here and thank the sponsors for their leadership and responsiveness. Thank you.
Thank you. Okay, now we will go to Dr. Mark Longshore online. Go ahead, please state your name, who you represent, and you have 3 minutes.
Okay, thank you. Good afternoon. Thank you, Madam Chair. I'm Mark Longshore. I'm a registered nurse and the Executive Director of the Colorado Nurses Association. And CNA has taken an amended position on House Bill 1002 seeking the inclusion of psychiatric nurses. So first, thank you to Representative Gilchrist and Brown and the other sponsors for sponsoring this bill to increase participation in health insurance by behavioral health providers, thereby increasing access to care in both urban and rural communities. Mental health care is increasingly provided by advanced practice registered nurses. One study found that mental health care provided by psychiatrists had decreased by 6%, while the care provided by APRNs had increased 162%, with psychiatrists and the APRNs treating, quote, roughly comparable patient populations with similar services and prescriptions. Another study found that states like Colorado, in which APRNs have full scope of practice, 48% of Medicare beneficiaries in rural counties are treated by APRNs. It's likely that similar numbers would be seen with other payers. With those numbers, it should be clear that APRNs need to be included in this bill. As such, CNA requests and welcomes the inclusion through amendment of the psychiatric nurse as defined in 13-21-117(1)B as a registered professional nurse who, by virtue of postgraduate education and additional nursing preparation, has gained knowledge, judgment, and skill in psychiatric or mental health nursing. This more inclusive language will better increase provider participation and subsequent access to mental health care for all Coloradans. Thank you to Representatives Brown and Gilchrist and the other sponsors for this amendment to include advanced practice nurses.
Thank you. Next, we'll bring up Susie Boldago online. Do you have her? No. Okay, that concludes this panel. Committee, do you have questions? Representative Bradley.
Representative Brown, I miss you more and more every day. Thank you. It's not often that the health plans and the insurance carriers, so I feel like I'm in a little bit of a twilight zone right now. But I think the thing that I'm struggling the most with is regulations. We're the 6th most regulated state, 45% are most duplicative. That's a hard word too. And so I'm wondering, why can't we just ask the plans and the carriers to do this? Because they already said that most of them are doing it. So why do we have to need another bill and another regulation to do this? That's where I'm struggling.
Let me take that. Mr. McFadden.
I'm not sure that I can specifically answer that question, though I welcome it.
You're welcome.
Go ahead. No. Mr. Longshore, do you have, did you want to try and answer that?
Well, I would say that following the status quo has gotten us to where we have what is already been described as these ghost networks. So that apparently isn't working. We do have consumers out there that are trying to get access to care and have to spend a lot of time calling different care providers and only to be told not on the plan anymore. So apparently more regulation is necessary.
Thank you. Committee, any other further questions? Okay, thank you so much. We'll bring up the final panel. Katie Rollins, William Richards, Alexis Altop, Amanda Carlson, and Erica Pike. I believe William Richards is remote, as well as Alexis Alta. Okay, we'll go ahead and bring up Deborah Kinder online. Kinder? All right, we'll go ahead and start with Katie Rollins.
Right here. It's Kate. Robinson. Thank you, Chair and Committee. My name is Kate Rawlinson. I live in Delta County. I'm the mother of a 33-year-old man who had the misfortune to develop a no-fault brain illness, disability in his late teens. I'm also here as the lead of Colorado Mad Moms, coalition of caregivers advocates who have grown to almost 500 in the last year and a half. There are an estimated 150,000 people, depending on who you ask, living with severe brain illnesses in Colorado. And we are one of the highest ranked states in the nation in terms of severe mental illness. Yet we're in the bottom 5 in terms of providing services and laws that protect people with these illnesses. I receive phone calls, as you can well imagine, weekly from these moms who are trying to get care for their loved ones. And it ranges all over the place, from healthcare to legal services, to competency issues, to trying to find housing and everything else. So, HB 1002, as you've heard, will effectively address, I think, several insurance and provider concerns that need to be improved or fixed, and that's great. What I'd like to speak about today is, in the strike below, the present bill is a significant change from the original. During the stakeholder meetings, decisions were made, and I'm just becoming aware of some of those today, that took the 6-month deadline that was in place for insurance companies to clean up these long directories of misinformation that they so proudly, frankly, provide on their websites. Now it says they have 12 months to do that. Now, there's some questions about exactly when that starts and when they have to get it done. So, but I would like for you to put yourselves in the shoes of a mom, of a caregiver, okay? And this is someone you want to protect. It's someone that, you're doing your best to get them care. You're fortunate. Again, this is imagination. You have private insurance, but you pay for it, perhaps through your employment. So you go to the website of the insurance company, you see a list of potentially dozens of local providers, especially if you live over here in the Front Range as opposed to the Western Slope. So you start calling them. It's frustrating finding a provider that works for your family, as I'm sure you have experienced in other illnesses. But imagine if you are the single parent and your loved one is in her room yelling at voices she is hearing. Or your son has tried to leave home to walk for hours around your neighborhood because it calms him down. Or your neighbors are usually not happy about that. Or is decompensating rapidly and has put a hole in the wall in your living room or his bedroom. Or your daughter is telling you she wants to die. Then you get on the phone and you start calling these insurance companies.
Thank you so much. Okay, well, next we'll move online to William Richards. Is William Richards up?
Yes, thank you. Thank you, Madam Chairman and members of the Health and Human Services Committee. My name is William Richards and I'm a proud member of Colorado Mad Moms. Our focus primarily is on addressing the needs of Colorado-based adults and youth with SMI, SBI, who are not receiving the services and treatment that they need and deserve. I support HB 1022 to ensure mental health care is treated with the same urgency and transparency as well as fairness with physical health care. This bill will help ensure that Coloradoans receive the care they need and already are paying for. Way too many families are being denied essential mental health care based on arbitrary or confusing insurance standards not just administrative problems. It is a matter of life and death in a state ranked 46th in available mental health care needs and one of the highest rates of youth and adults with serious thoughts of suicide. When insurance companies deny coverage, people are forced to postpone or forego necessary treatment they are needed. This leads many to worsening conditions and increased reliance on emergency room visits and crisis services. Between 2016 and 2021, Colorado saw a whopping 158% increase in ER visits by our youth experiencing mental health symptoms. Behind each visit, it's not only the individual that is suffering, but the family is put into distress mode and lives upended by addressing the denial of care. I ask the committee, I urge them to continue to support continued efforts in advancing HB 25 and 22. Thank you.
Thank you. Next, we'll go to Alexis Alton, online. Can you please state your name, who you represent? You have 3 minutes.
Yes. Good afternoon, Madam Chair, Vice Chair, and members of the committee. My name is Alexis Alton, and I am testifying in support of House Bill 1002 on behalf of Healthier Colorado. Too often, Coloradans seeking mental and behavioral health care encounter ghost networks, where provider directories appear robust on paper, but in reality include providers who are no longer in network or those who are no longer accepting new patients. For Coloradans, this can mean making call after call to providers listed as in network without actually being able to secure an appointment for critical mental health treatments. Inaccurate directories can also lead people to inadvertently seek care from a provider who was formerly in network but no longer accepts their insurance, leaving people with unexpected out-of-pocket costs. The requirements for health plans to confirm provider participation in a timely manner represents a significant step in alleviating the burden of trial and error for patients, and will help improve access to in-network providers for Coloradans. House Bill 1002 will also provide meaningful support to Colorado's behavioral health workforce. Early career professionals often experience delays in joining provider networks due to long credentialing timelines or artificially full networks. Ensuring inaccurate providers are removed from networks in a timely manner will help create space for these providers that are eager to join the networks and accept new patients. Reimbursement for pre-licensure candidates will also help reduce barriers to enter the mental and behavioral health profession, which is particularly important as we try to diversify the state's behavioral health workforce. This bill also incentivizes providers to supervise pre-licensure candidates, which is an important way that we can broaden the workforce pipeline. House Bill 261002 will ensure that our state has the workforce and access to in-network care needed to meet the needs of Coloradans, both now and in the future. And I respectfully request your yes vote on this important bill. Thank you for your time and consideration, and I welcome any questions you may have.
Thank you. Next, we'll go to Amanda Carlson.
Good afternoon, members of the committee. My name is Amanda Carlson. I am the Policy and Advocacy Manager at Colorado Consumer Health Initiative. CCHI is a nonprofit, nonpartisan, member-based organization that serves the interests of Coloradans and consumers who face structural barriers to high-quality, affordable access to care. I'm also a social worker, and Madam Chair is not here, but I am a student at House District 8. I'm here to express our support of HB 1002 and ask for your yes vote on this bill. While access and affordability issues exist across the spectrum of health services, we hear time and time and again from community members that these barriers are especially high when accessing mental health care. As has been said by some of my fellow proponents, insurance companies can have slow, confusing, and inconsistent processes to prevent qualified mental health providers from joining insurance networks and getting paid for their work. As a result, there could be fewer providers available to patients, and the workforce is smaller than it should be. This results in limited options for patients, lack of culturally competent providers, and higher costs for out-of-network care. Coloradans are 18 times more likely to be forced to use an out-of-network provider for mental health than for physical care. For consumers, navigating the healthcare system can be difficult enough without having to chase down providers within their ghost networks for time-sensitive care.
Directories can list providers that are unavailable, not accepting new patients, or not actually in network. This is an avoidable barrier for consumers seeking vital mental health services. This bill takes important steps to improve in-network mental health care, quicken the approval process for provider applications, and in turn reduce costs for Coloradans. It will verify provider participation in their networks and make sure patients have accurate information to who is offering care. We have an opportunity to update Colorado law with these clear common sense rules and standards for credentialing, billing, and reimbursement of mental health providers, which would eliminate ghost networks. This bill would expand the mental health workforce and mean more Colorado families will be able to get the vital mental health care they need. I urge for your yes vote on Bill 2.
Thank you. Next we'll go to Erica Pike. Please state your name. You have 3 minutes and who you represent.
Thank you, members of the committee. My name is Erica Pike. I am a policy and advocacy specialist with Children's Hospital Colorado, and thank you for your time and the sponsors and all the work that's been put into this bill. We're here today in support of the amendments being offered by the bill sponsors. As a unique safety net provider and trusted community resource, Children's is one of the most comprehensive providers for youth mental health services in Colorado, treating kids from all 64 counties. Across 4 hospitals and many outpatient sites across communities across the state, we treat the most children in mental health crisis through our emergency departments. We are one of the largest providers of outpatient care, and we provide inpatient care. We care deeply about the health and well-being of children in our state and desire to preserve, expand, and improve their access to all aspects of mental health care. Colorado is facing a youth mental health crisis, yet children and families, including one sitting at the table with me today, across the state regularly face unnecessary barriers to finding the care they need due to unequal standards for mental health care through the various insurance processes. More than 75% of Coloradans with commercial health insurance who have been diagnosed with mental health conditions have not yet received treatment. And only 22% of youth in the state who have a mental illness are receiving care that they desperately need. Why is this? One of the reasons is mental health parity. You hear that word? And what it means is that insurers in our state and across the nation treat mental health differently than physical health. This bill takes another step in trying to enforce mental health parity laws by aligning the credentialing timelines that our physician colleagues on the physical side get 60 days with today's amendment. We're also really grateful for the work on reducing inaccurate provider directories, which often send our patients and parents like Kate down rabbit holes trying to connect with providers in their communities who are no longer accepting patients. Please vote yes on today's amendments to HB 1002 with this important step that our state can take to ensure we continue and try to treat mental health and behavioral health equal to physical health. Thank you, and I'm happy to answer any questions.
Thank you. Next we'll go to Deborah Kinder online. Please state your name, who you represent, and you have 3 minutes. You're on mute. Please unmute yourself. There you go.
Okay, great, thanks. Back up. My name is Debbie Kinder, and I'm a member of Colorado Bad Moms. I urge you to support HB 261002, provider participation and health insurance. Finding a mental health care provider who participates within a health care insurance plan is a daunting task. By the time our son reached the tender age of 6, he had already exhibited high-risk behaviors and depression. I vividly remember telling him as he laid motionless on the couch that we were going to get him some help. He met my gaze and said, "No one can help me." I felt as though I was looking into the soul of an old man in a little boy's body. No person seeking help should be put into the position of being told, "I don't know why you call me, I haven't been in your network for some time," yet that is precisely the kind of responses we get. Patients don't need the runaround from their insurance companies. This bill places the responsibility on health insurance companies to ensure that their provider lists are accurate and up to date. Federal legislation passed last week was co-sponsored by Senator Michael Bennet. The Requiring Enhanced and Accurate List of REAL, as it was called, Healthcare Providers Act, works to ensure Medicare Advantage plans maintain accurate provider directories. Passing HB 261002 would go beyond federal legislation and ensure that all Colorado's health insurance plans should clean up their directories. Thank you.
Thank you. Okay, committee, do you have questions? Representative English?
Thank you, Madam Chair. Ms. Kate, can you finish your thought? Thank you.
Sure, I guess I really just would like to say, the big issue here is you could save a hell of a lot of money that you're gonna spend in the future on people who have reached adulthood because they were not given early intervention, okay? The sooner we can get people care, the sooner we can actually get our providers up to speed, because unfortunately that is an issue in many cases in terms of their training. We can save ourselves so much money in other areas. We can do better. Colorado, you don't have to be in the bottom 5. It's embarrassing, and it's a shame. So my feeling is, we all gotta do our jobs. We gotta work together, we have to do our jobs, we have to fix this system because it's just getting worse. And it's not gonna be better until we get in the room and decide it's important and we need help. And they deserve to have the same quality of care as your kids, parents, everyone else gets, okay? And that's not happening. So I'll just stop there. Let's look at this bill more closely and get the dates. The insurance companies have plenty of technology to reach out to all of their providers and figure this out. So why are they being allowed to not do their jobs? Thank you, everyone.
Thank you. Representative Hammer.
Thanks, Madam Chair. My question was the same as Rep. English's, so ask and answer. Thanks.
Thank you. Any further questions, committee? Okay. Is there any witnesses that has not signed up that wishes to give testimony? Thank you. All right. Seeing no other witnesses, online or anywhere? Thank you. The witness phase is closed. Bill sponsors. Do you have any amendments?
Thank you, Madam Chair. We do. We have 2 amendments that Representative Brown outlined earlier. So I move L002 to. Apologize. I move L001 to House Bill 1002. Second.
Seconded by Rep. Ray. Okay. Committee, do we have any questions? Do you want to explain the amendment? Representative Gilchrist?
Thank you, Madam Chair. I think we'll move the next amendment and then,
Okay.
thank you. So I move L002 to L001.
Thank you. Seconded by Representative English. Okay, do you want to explain the amendment? Representative Brown.
Thank you, Madam Chair. Yeah, so the amendments, so L002, which is before you right now, is a amendment that makes sure that the definition of psychiatric nurse is included in the bill as one of the professions that we're talking about here. We worked with, obviously, with folks in the advanced practice nursing community as well as with the insurance companies, and we'd ask for an item on L002.
Thank you. Committee, is there any questions on the amendments? Is there any objections to the amendments? Okay, seeing none, the amendments passed.
Okay.
Is there any more amendments?
know, do we have to, we just passed L002, do we need to pass L001 now? Yeah, okay.
You have a question? Okay, Representative McClure.
Thank you. My question's on L001. Just a little more background, if you could, Representative Brown or Gilchrist, on the conversations that went into changing the not submitting a claim from 6 months to 12 months. Just a little more feedback on what you heard through your stakeholding process to get to that number. And it looks like you also added language that required the carriers to update this list once a year. That wasn't in the original bill, I don't think. So if you could just give us a little more background on that, please.
Representative Gilchrist.
Thank you, Madam Chair. So on your first question, thank you, Representative McCormick. So we had heard back that oftentimes, providers, like if someone was pregnant and had a baby and might not be responding, we want to give a little bit more time. We also heard from insurance carriers that extended time period would make it a little bit easier to keep those up to date. So we felt like it was a good compromise.
Any further questions? Representative Brown.
I'll just add that the division reviews networks once a year through the plan documents that are submitted during the rate review process. And so the annual timeline is consistent, at least with the department's network adequacy reviews. So there is a nexus there as well. But I mean, I certainly understand what the testimony was saying about. We want to make sure these provider directories are accurate, and that these provisions move us along in a much better way than the current law.
Thank you. Again, is there any objections to the amendments or anything? Okay, thank you. Seeing none, would you like to make some concluding? Yes. Both amendments have been adopted. Also, the one. Would you like to concluding comments?
Yes, thank you, Madam Chair.
Gilchrist.
So just want to reiterate that we all know that there is a mental health crisis in Colorado and across the country. And the stories that you heard today from the folks with lived experience and the story that I told as an example are real stories of individuals, of parents, of individuals in mental health crisis that can't find a provider. And so we have to do better for Coloradans, and we need to make sure that both we have the needed providers and those providers are accessible, and this is doing that. It is getting a step closer to that access that is so desperately needed by so many people. And I'm grateful for the many folks that came and testified today, and for as Representative Bradley mentioned, Twilight Zone level of collaboration here that got us to this bill today. I'm so grateful for my colleague Representative Brown for all the work that he's put into this, and both of our deep commitment to addressing the mental health crisis across the country. And I vote today.
Representative Brown.
Thank you, Madam Chair. I want to thank the committee for for hearing the bill, for listening to us. I think this is a really important step. It's something that, first of all, just on a technical piece, I just want to make sure that everybody understands that, of course, as one of the witnesses from the Association of Health Plans mentioned, the credentialing process includes a signed contract. So if there was any concern about that, that's something. On a more general point, I think this is an experience that many of us have had. Trying to find an in-network provider is hard enough. Going to your insurance company, finding a provider directory, calling around, trying to find a provider that's either taking patients, still exists, etc. It does not surprise me that the U.S. Senate Finance Committee, in their secret shopper surveys, found this to be true, because I think everyone who's ever interacted with healthcare knows that this is a problem. So the idea that we can move in a different way, that we can use the claims process, and we can use some very, I think, low touch standards to make sure that our provider directories are clean is really important here. We're taking a number of steps throughout this bill to augment our behavioral health workforce, and specifically our behavioral health workforce in private insurance, where often folks struggle the most to find behavioral health services. So I'm really excited to move this forward, and really hope you'll support the bill today.
Thank you. And just for the record, the amendment phase is closed, so no fast ones, Okay. Committee sponsors, do you have any closing remarks? Representative Bradley.
Thank you, and thank you both. I do think it takes an act of the Lord to get all these people on the same page, and I applaud you, because stakeholding in this building is rough, and I applaud someone I consider a dear friend who worked behind the scenes on this bill. I can't get there today. I hope that you guys can pull me aside and have some private conversations with me. For me to be a healthcare worker, and when the government keeps intervening and private insurance carriers, and I don't see real results of provider roles being kind of cleaned up, then I hesitate to add another bill that might stack to the problem. I don't think that's what you got. I know both of your hearts, even though we couldn't disagree more. I know what your hearts are for mental health in this field, and so I wanted to go on the record saying that I just don't know that this is a solution to the problem in the 6 months regulated state. That's the only reason I'm a no, but I hope that we can have some off-mic conversations, and we can talk a little bit more towards it, because I'm not offering a solution either, and that is my biggest pet peeve, when people are like, no on your bill, but I don't have a solution for you either. So I get what that sounds like, and I'm hoping that, again, we can have more conversations. I appreciate your stakeholding. I appreciate you bringing so many people to the table, and thank you for everyone that came here to testify.
Any other closing comments? I would just like to thank you for bringing the bill. Something definitely needs to be done. And with that, Clerk Gilchrist, would you like to move your bill? It goes to the Committee on Appropriations.
Thank you, Madam Chair. I move House Bill 1002 as amended to the Committee on Appropriations with a favorable recommendation.
Second. Ms. King, would you like to take the roll?
Representatives Barone,
Yes.
Bradfield,
Yes.
Bradley,
Respectfully, no.
English,
Yes.
Beret,
Yes.
Hamrick,
Yes.
Johnson,
Yes.
McCormick,
Yes.
Ryden,
Yes.
Stewart K,
Yes.
Wood,
No today.
Gilchrist,
Yes.
Madam Chair.
Yes. That bill passes 10-2. Thank you so much.